Aye.
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 We need to do voice on that.
Aye.
Roll call. I mean, do we need to do roll call on that, Mr. Sanders?
Yes, do a roll call. And also you said you had a quorum, and I agree with you. It looks like you do, but nobody's taken roll yet.
Okay, we got to take roll. Sorry. Narda.
This is Narda Capicelli. I'm taking roll. Dr. Drake,
Here.
Dr. Gotcher is not here. Dr. Hurt,
Here.
Mayor Jacobs,
Here.
Dr. O'Brien,
Here.
Ms. Roma,
Here.
Dr. Shamia,
Here.
Dr. Sousa,
Here.
Ms. Wagner,
Present.
and Dr. Buchanan.
Here.
Thank you. 9 present, 1 absent. Thank you.
So you'll still need your roll call vote on the,
So make a motion that Dr. Souza chair the meeting.
And I'll second that.
Now Narda will need another roll call on that one.
Okay, this is Narda Capicelli taking vote number 1. Dr. Drake,
Yes.
Dr. Gotcher is not here. Dr. Hurt,
Yes.
Mayor Jacobs,
Yes.
Dr. O'Brien,
Yes.
Ms. Roma,
Yes.
Dr. Shamia,
yes.
Dr. Sousa,
I guess yes. I'm not sure if I should abstain.
Your vote.
Okay, sure. Yes.
Ms. Wagner,
Yes.
and Dr. Buchanan.
Yes.
9-1. Thank you. 9-0, really. Thank you.
All right. I guess that being said, I think next on our agenda is the public forum. And I believe that the folks at the health department are going to handle that for us, if I'm not mistaken.
Yes, we are.
Yes, this is Kelsey Wilson. I'm the Division Director of Communications for the Health Department, and I'll be helping with Public Forum today. The first individual we have, Christine Cruz, has not joined yet. Neither has Elizabeth Murphy, who I believe is our second. Let me just double check. No one, okay. So the third person we have, Mr. Kevin Hill. If you can join, you can turn your mic on and your video on and provide your name, address, and you have 3 minutes, which the folks at IT will pop up a timer, and you can get started whenever you're ready.
I'm attempting to start my video. There we go. Okay. Let me get my comments in front of me. Okay. My name is Kevin Hill. I live at 509 Cambridge Street, Knoxville, Tennessee. All our measures seem to start out on the promise of weeks and turn into months. Now we no longer talk about preventing deaths. We're trying to prevent cases, but the measurement tool, the PCR, has proven so sensitive that it can test positive for either dead viruses or other forms of coronavirus. Nationally, we are at a lower number of overall deaths in 2020 versus 2019. Given our success locally till now and lower COVID-19 deaths, it would seem we are consistent with that overall national trend regarding overall deaths. However, what we do know in our local areas, our drug deaths are up, our suicides are up, and the number of scene visits by the medical examiner where the persons appear to have died at home, avoiding the hospital or not receiving hospital services are also up in 2020. So while our board obsesses on scientifically questionable practices, we have not heard word one about scientifically proven data like the role of vitamin D3 deficiency in hospitalized COVID deaths or other therapeutics that are proving effective and protecting from or minimizing the impact of infections. I'm sure we will hear much about our increases tonight, Possibly, if we quit trying to control social behaviors and focus on good health preventions and therapeutics, we might see better results. It was not until our board radically began interventions that our cases and local impact dramatically increased. At this point, it is fair to say our county-wide policies are resulting in a negative public health impact constituting malpractice. What could motivate such dangerous behavior? I have discovered that in addition to traditional means of compensation, hospitals in Tennessee receive $166,000 per admitted COVID-19 patient dispersed from the CARES Act, which openly states institutions will not be reviewed for fraudulent claims. Shouldn't our community be concerned that a high-level administrative officer for a local hospital that financially benefits from the CARES Act is part of setting the policy for our community's COVID-19 public response, especially when sources have communicated that the medical examiners altered the cause of death on some death certificates because, in her opinion, it was not a legitimate COVID-19 death. And we don't have time to address the statements by the CDC or the WHO on their websites that openly admit the lack of science confirming the efficacy of wearing masks to prevent spread of virus. However, even more important than the lack of scientific merit, another state Supreme Court and a federal court have both ruled that the actions of our board are illegitimate in the United States of America. Move to a communist or socialist country if you want to act the way you do. I hope the public and our media will rise up and hold this board to account for why it is so motivated to ignore our constitutional rights in the face of these facts. Thank you.
Thank you, Mr. Hill.
All right, thank you, Mr. Hill. The next person we have for public forum is Anastasia Juneau, who I do not believe is in yet either. So the next person we have is Richard Cunningham. Richard, you can turn your camera and your mic on, provide your name and address, and you have 3 minutes, and the IT folks have the timer up on the screen.
All right, thank you. Richard Cunningham, board certified orthopedic surgeon, Knox County resident for over 20 years, small business owner. My zip code is 37932. Thank you, Mayor Jacobs and the board for this opportunity to address you. Many of us recall Knox County setting up a reopening task force. This group was charged with spearheading the reopening of our economy after a devastating lockdown, which included untold job losses, suicides, drug overdoses, broken families and marriages, and economic destruction. We were well into the reopen when in late June it was announced the task force was disbanding. And then July 1st, Knox would begin following the state guidelines known as the Tennessee Pledge. However, on July 1st, the Knox Board of Health, an entity many of us never even knew existed, issued a mask mandate punishable by a Class C misdemeanor, meaning fines and/or jail time. Most of us in Knox County were stunned that a board, which was deemed advisory only, would threaten the citizens with such a mandate, punishable by fines and jail time. Now, some of you like to point out that no one has been fined or jailed as a result of your mandates. I would simply reply, yet. If you really feel that way, then lift the mandates and emphasize education. Otherwise, the threat remains despite your words. When you decided to issue mandates with punishment, you became accountable. You like to say you are accountable to state boards, your peers, etc., and you were vetted by county commission. You have resisted public forums such as this. Only Mayor Jacobs has responded to my emails. County commission rebuked you for good reason, as you've exceeded your mission. This same county commission listened to more public input at a single meeting than you have in 15 meetings. And you forgot the most important group you're accountable to is not a state board or your peers, it is the citizens of Knox County. Why are you meeting via Zoom? Yet county commission meets in person for many hours. What message does that send other than fear to our citizens? I've watched many hours of your meetings, and the most common terms I hear are anecdotal, I feel, we know it works, it just makes sense, I've been told, I did a drive-by, etc. No real data, no real studies to support anything. And the myocarditis study presented 2 weeks ago was simply a scare tactic presented, and it was a debunked article. Lastly, I will close with the most important point, which is testing. I would challenge each and every one of you to learn what PCR testing is, what it means, and what cycle amplification means. Every metric you use is tied to this, yet I doubt many of you have any idea what it is. I will tell you that none of your numbers are reliable, none of them. The tests do not detect the actual virus. They do not mean the person is actually infectious or contagious. And most importantly, do not mean the person is actually a case, despite how it's reported. And finally, the CDC just reported that 85% of positive COVID patients always or often wore a mask, while 4% never did. That simply speaks for itself. Rescind the mandates. Thank you.
Thank you, Mr. Cunningham.
All right, the next person, the last person we have on our public forum list today is Julie Grubaugh. Julie, if you can turn your video on and your mic on and provide your name and address, and you have 3 minutes.
Thank you. Hello, I'm Julie Hansen Grubaugh. I live at 37909. Hello and good evening. My sister, Elizabeth Hansen, a pathologist assistant and Knox County resident, wrote the words I'm about to share. And because public health is a team sport, and because she's working tonight, I'm going to share her words, with which I wholeheartedly agree. First, I want to thank you for your tireless work. Thank you. I hear the stress in your voices and recognize the position you're in and see that you work to balance the needs of the business community with the very real threat to all of us. Here are my brief remarks. In early spring, when coronavirus was new, fear of the unknown motivated us to lay low and be safe with a unified message of flatten the curve. Since then, our community has experienced peaks and plateaus in COVID-19 infections and deaths. By now, pandemic fatigue is real. You must feel something like a broken record recommending the 5 core actions and defining and refining mandates aimed at mitigation. In spite of mitigation efforts, our community is entering an alarming phase defined by the highest numbers of people hospitalized with and dying from COVID-19 since the beginning. I'm deeply concerned for the safety and the morale of our public health and healthcare workers in system capacity. I speak from a place of frustration and disillusionment at how evidence-based recommendations are conflated, confused, diluted, and lost under a tsunami of misinformation that circulates and burns through our community as a destructive wildfire, leaving death and disease in its wake. Adherence to the 5 core actions is uneven, and resistance to them has in some cases become outright hostility directed at each of you. That is not your fault, and arguably it's not your responsibility. Yet here we are. So what can be done? My big ask is that we, as a community, form some sort of group or committee that addresses in real time the circulating memes, articles, and videos on social media, and that translates science into regular speak. Elizabeth Hansen volunteers to help to be part. I volunteer as well, and thank you.
Thank you, Ms. Grubaugh.
Right, and
And I'll hop on.
sorry, Dr. Souza, that was it. The other 3 individuals that were on the public forum list have not tried to access the meeting. So those are the 3 that joined the meeting.
Okay. Thank you. I guess we'll move on to the next thing, which is approval of the minutes from our previous meeting. Hopefully everyone had a chance to review them.
Before we move on, may I have the floor for just a comment about public forum and the repeated accusations of PCR inaccuracy? The PCR is a standard test that we use throughout medicine for not just COVID, but for many, many other tests. It's a reliable test, and you can't amplify a virus that's not there. If the virus particles aren't there, it won't be detected because it can't manufacture virus protein. The manufacturer sets the threshold that the cycle threshold that everybody's so concerned about. And cycle threshold is also a standard in PCR testing. It's what we use. It's a standard in medicine. It's a reliable test. And the PCR is actually our gold standard for diagnosing COVID-19 and many other things as well. In addition to that, it actually produces more frequently a false negative, meaning the person has disease but we can't detect it, than it does a false positive where they don't have the disease and we say they do. So it is a reliable test, and I just think the public needs to hear that. It's the best test we have available at this time. And I don't know if Dr. Shamia wants to speak to that. It's certainly a tool they use at the hospital regularly for diagnosing the COVID and many other things as well.
I agree. I really have nothing to add there.
Dr.
Thank
Souza,
you.
I'm permitted to ask a question.
Sure.
I was wondering if it's also consistent with the type of test that's being used across the state of Tennessee, across the United States. And I'm also wondering, why is there pushback? I was listening to Forum, but I don't quite understand why there's disbelief. When I hear Dr. Buchanan, you saying this is the gold standard, this is the best tool we have right now. So those are my two questions. Is this what's being used more widely, and why where's the confusion coming from, if you know?
So for your first question, yes, this is a test that's being used nationwide and around the world to detect COVID. And so it's not just unique to Knox County or Tennessee. It's used around the world and across the country. I'm not sure where the pushback is coming from or where the confusion comes from. I think there's like many other things in science, it's hard to understand. It's complicated. It's a laboratory science is a very complicated science. And trust the folks at the Tennessee Department of Health and the other laboratories here who would say this is a reliable test. And I'm not sure, I don't know if anybody else knows where some of the pushback and confusion is coming from.
Thank you.
Any other comments on PCR test, Dr. Bryan?
I'm just going to move that we accept the agenda.
Okay. Do I hear a second?
Second.
Oh, actually, we've got to approve minutes first, don't we?
I move we approve the minutes.
I second it.
Any discussion? Hearing none. Narda, could you do a roll call?
This is Narda Capicelli doing roll call for the approval of the minutes for 9/30/2020. Thank you. Dr. Drake?
Yes.
Dr. Gotcher is not here. Dr. Hurt?
Yes.
Mayor Jacobs?
Yes.
Dr. O'Brien?
Yes.
Ms. Roma?
Yes.
Dr. Shamia?
Yes.
Dr. Souza?
Yes.
Ms. Wagner?
Yes.
And Dr. Buchanan?
Abstained since I was not here last time. So
Thank you. 7-0. Thank you.
Madam Chair, one of our public forum speakers has, she's been here, we just didn't recognize the name. We'd like to let her in so she may speak. Is that okay?
Yeah, that's fine. Which one is she?
Christine Cruz.
Okay. Sure, we can hop back for just a second.
Okay, thank you. Sorry, I muted you.
Hi, Christine Cruz. If you can hear me, we can get started in your addition into public forum. If you can turn on your mic and your camera, you have 3 minutes. You just need to provide your name and your address.
Oh my God.
Hi, Christine, can you hear us? Christine?
Ms. Cruz, if you can hear us, please respond.
I'm sorry, I can't hear. Okay. This is my first attempt, so I apologize for holding everybody up. Can you hear me?
You can, thank you. You may begin.
Okay. The original goal of the mandates and the shutdowns was to flatten the curve, not to reduce COVID-19 infections and death to zero. Over time, the goal has shifted to reducing COVID deaths at any cost, as if it were the only cause of death that mattered. COVID-19 overwhelmingly affects the very old and sick in society. The median age is between 80 and 82 years of age. These people, many of whom reside in nursing homes, are statistically within their last months and weeks to live due to many factors. These represent 40 to 50% of all COVID deaths in the US, which is roughly about 100,000. Many experts agree that the focus of restrictions and protections should be on those at greatest risk, the elderly and immunocompromised, not the healthy people in society. This is confirmed by world-renowned epidemiologists from Harvard, Stanford, and Oxford universities with the recommendations that there should be a focus on allowing most people to live their lives normally to build immunity through natural infection. We also need to improve safeguards for the elderly and immunocompromised who are at greater risk of death from COVID-19. Schools should reopen based on the data that children are not at risk for death. More influenza deaths at roughly 180 in 2019 versus about 15 from COVID-19. More people older than 100 years of age worldwide died than children less than 30 years of age. So I think that the people of the community are very concerned about the greater effects on the other effects of shutting down society versus what this virus is posing as a threat. So I think it needs to be reevaluated, and people who oppose you are not threatening you, and that's just for the record. Thank you very much.
Thank you, Ms. Cruz. Did we have anyone else join in that had missed the first round?
We did not. Thank you.
Oh, okay. So I think we can move on to approving the agenda. Do I hear a motion?
Move to approve the agenda.
Can I get a second?
Second.
Thank you. Any discussion? All right, Narda, can we do a roll call on that?
Yes, ma'am. This is Narda Capicelli, and we are taking, we are setting the agenda. Dr. Drake?
Yes.
Dr. Gotcher is not here. Dr. Hurt?
Yes.
Mayor Jacobs?
Yes.
Dr. O'Brien?
Yes.
Ms. Roma?
Yes.
Dr. Samia?
Yes.
Dr. Sousa?
Yes.
Ms. Wagner?
Yes.
And Dr. Buchanan?
Yes.
Thank you. Passed. Thank you.
Excellent. Thank you, Narda. So next on our agenda is Dr. Matt Harris is going to join us from UT. He's an economist, and I think at our last meeting we had some discussion about looking at economic impacts of the various mandates and policies, and hopefully he can maybe give us a little bit of insight on those. Dr. Harris, you've got the floor.
Thank you. So for those of you I haven't formally met, I'm Matt Harris. It's nice to meet you. I'm an economist at the University of Tennessee. And my research and expertise lies at the intersection of health and labor economics. And when you strip away all the jargon, most of what I spend my time working on is why people make the choices they make, why they allocate the resources that they do. And consider how, as the world changes, as conditions change, how people's decisions change in response to that. and how that affects outcomes that we care about. So as a preamble to anything that I tell you, if you ask an economist, should we do more of something? The answer across the board is going to be yes, if the benefits of that thing exceed the costs, but no, if the costs are at least as great as the benefits. So and this one isn't mine. I have to attribute this to an acquaintance at BLS. I'm not here to tell you what you should do, that the glass is half full or the glass is half empty. I'm here to talk about a 16-ounce glass and the 8 ounces of water in it. That's kind of the economist way. I want to talk briefly about where we are, and how you feel about that is up to you. So what do we know? We know that about 7 months ago, we as a nation began to very rapidly take the threat of COVID-19 very seriously. Over the next few months, there were a number of changes, but we can broadly categorize those changes into two categories. One is there's changes in the policy environment, and that entailed both regulatory changes and changes in government spending to mitigate economic damages. Two, individuals and organizations began changing their behavior in response to the threat of COVID-19 in advance of, and sometimes independently of, government or policy changes. We call these things avoidance behaviors. And in this type of conversation, they have to be taken very seriously. Most people are somewhat risk averse. As an example, one of our former grad students, Beth Glenn, had a paper where she found that cases of paralytic polio in an area, in a state, a large area, resulted in people holding their kindergartners and first graders out of school, even though the objective probabilities of that was very low. By a similar token, there's plenty of evidence that when there's water quality violations, people switch to bottled water. When there's high ozone pollution days, particularly on the West Coast, people will stay home. And those behaviors are not costless. We know that the pandemic is still ongoing and that we're in a recession. Now, what makes this recession different than the other ones that I've seen is not that revenues are down. That happens in all recessions. But in this one, there's a remarkable pattern of redistribution. You have sectors in the recession that have done exceptionally well, and there have been of those that have been really adversely affected as well. And the pattern shouldn't be a surprise. The following numbers are preliminary, but when we compare this August to last August in terms of sales tax receipts in Knox County, clothing stores were down 20%. Restaurants and bars are down 15%. Gas stations, the same, are down 15%. But overall, retail sales are up from last August. E-commerce is up 22%, but so are building materials and garden supplies, which are up 15%. Sporting goods and hobbies, which are up 11%. Grocery stores are up 10%, et cetera. So the story is not, in this case, about widespread economic devastation, but about really pronounced patterns in substitution. Individuals have changed the way they've spent their money and changed the way that they spent their time in response to the pandemic. And overall, sales tax receipts for the year in Knox are up 13% this year over last year. Now, there's some important changes in sales tax collection and attribution that have also changed over the last year, but that 13% gain for Knox County likely understates the overall increase in taxable transactions, all of this in spite of record unemployment claims. So we have this tremendous shock, COVID, individuals changing their behavior, regulatory and policy changes have both played a part. And 7 months later, here we are. Unemployment rates in Knox County are up last year. They're up to 6.5% at the last estimate that we have, but that's well below the state average of 8.5%, let alone the estimates for the other major urban counties in the state. Davidson and Shelby are at 10 and 13% respectively. So in a situation like this, we have people who've been made better off or worse off. The people who you're most likely to get the most vocal discussion from are the people who have been the most adversely affected. And so when we think about what to do going forward, ideally would have evidence-based policy with a cost-benefit analysis for each component of any sort of considered set. But right now that's infeasible for a number of reasons. One, among the survivors, my understanding is that I'm not a health scientist, that science is still trying to understand the long-term ramifications of COVID-19. And second, assessing the impact of a particular regulation is difficult because there is no such thing as a counterfactual Knoxville, some doppel Knoxville, that's trending along as we would have been in the absence without any regulations at all. Not only that, when we look at different jurisdictions across the country, there's bundles of regulations in place in most places, but the details of those differ in ways that make comparison difficult. And finally, for circumstances like a pandemic, the dynamics of policy responses matter a lot. And the reason they matter a lot comes back to avoidance behavior. When we look back in March through May, one of the most striking findings is that private self-regulating behavior explains over 3/4 of the decline in foot traffic in discretionary industries, meaning restaurants, hotels, entertainment, non-essential retail. This is from a team at Notre Dame. A team at MIT found a slightly lower number. They found that local information about the trajectory of case counts, as well as national level information, and same with death counts, was as important as the stay-at-home orders when affecting retail traffic. So private information, the individuals making choices in response to the world they see, that's going to matter a lot, regardless of the environment the policy environment that's in place. So why is this important? It's important because if you loosen restrictions, yes, some people will be happier. Your bar owners will be happier. Young people and people who enjoy going out and staying out in those bars will be happier too. But we also know that alcohol consumption affects judgment, and that's going to be problematic. Case counts are going to increase. And when these counts do increase, the people going out and staying out and enjoying the environment are unlikely to change their behavior. But some of the rest of the consumer base will change behaviors. People are going to engage in more avoidance behaviors than they do now when case counts are relatively well controlled. Some people will not go out to dinner like they do right now. More people will substitute online retail for in-person retail and affect broadly the retail sector across Knox County in general. Gasoline sales will decline as people reduce unnecessary travel. People are less likely to engage person-to-person services, and certainly not at the frequency that they do. And not all people will do this, but enough to where you'll see it, enough to where it'll matter. These changes in avoidance behaviors from higher case counts are likely to affect a much larger share of the businesses in the county than the ones who are seeking relief right now. So what I want you to take away from this is that there are trade-offs to the choices that we make. And not all of the consequences of those trade-offs are immediately obvious, but they're nevertheless there and must be considered when making good policy and figuring out where to go next. As far as masks go, even Goldman Sachs is holding that masks are good for GDP right now. Their emphasis is on that masks are reducing infections and will avoid more intense restrictions. But the big one, in my opinion, from economic impact back to not setting off a chain of avoidance behaviors where people are just voluntarily staying at home and not engaging in the services sector and in retail. And that's the main thing, is you can do business with a mask on. You cannot manufacture an X% increase in demand because X% of your customers are staying home again because case counts are increasing. And pandemic dynamics are hard to estimate, let alone the magnitude of the responses to those dynamics in a highly localized setting. And that's why ex-ante economic evaluation of these policies is likely to be highly sensitive to the assumptions necessary to conduct them. We know two other things about masks. One, they've been shown by every credible research team that I've seen in reducing infection rates. Two is people are more likely to engage in risky behaviors when there's peer pressure or stigma. If you make masks voluntary again, those forces are going to lead to even less frequent mask use than what we'd otherwise see based upon individuals' preferences alone. That will affect infection dynamics and subsequently affect avoidance behaviors and will yield ripple effects in that economic impact. And that much we do know. It's about the magnitudes of which we're uncertain. So that's a few starter thoughts. And part of the reason I was asked to be here tonight was that there had been a suggestion on the floor, I believe at the last one of these meetings, which I didn't attend, that economic impacts be done on a prospective regulation or policy before it's implemented. And the two things I want to take away tonight are, one, that there are trade-offs from the policy choices that get made. And two is that my concern with the amount of assumptions that have to be made about the various margins of response is I would be very leery of trying to have a precise economic impact estimator for a prospective policy. Make sure it's not assuming its answer and the assumptions that it makes to get you a number. So that's a few thoughts. And if you have questions, I'm happy to talk.
Thank you, Dr. Harris. Does anyone have any questions or comments? You stumped all the medical professionals.
Not talking about medicine.
No, this is great. I just want to say thank you. That's a lot to digest. But thank you for coming, for providing us with data. It's actually encouraging to know that locally, things aren't as devastated as economically. There's not the economic devastation that, of course, we all are concerned about. So it was encouraging to hear some of your data, and to hear the science behind risk aversion and risk avoidant behaviors. What's the word? What's the phrase I'm looking at for? Also loosening of inhibitions when due to peer pressure or certain activities. I think I'd like to say that I, for one, and I feel this is generally true of all of us on the board, we are cognizant of every meeting of the decisions we make and their impact on our fellow citizens. We're not making them in an ivory tower bubble, but it's really nice to have someone with a different perspective contribute to our discussion and our decision making. So thank you.
You're welcome. Anytime.
Any other comments or questions for Dr. Harris? If not, I second what Dr. Hertz said, and we very much appreciate having a little bit different perspective. And I'd reached out to one of your colleagues in the Baker Center, and he had kind of given me a quick rundown, similar view of that it's really hard to look at all of these different mandates and policies that go into place and piece them out without a Doppler Knoxville, as you said, Doppler Knoxville.
My pleasure. Thank you for having me.
All right, thanks. All right, so next on our agenda is the Knox County Health Department presentation. I believe Dr. Buchanan is going to do that.
You're correct. Thank you. So I'm going to let Catherine pull up our stuff. While she's doing that, I'll just kind of run down our local situation for today. We have 64 new confirmed cases since yesterday, giving us 11,234 confirmed cases of COVID since March. We have 527 probable cases. 10,457 of our cases are considered inactive, giving us 1,214 active cases. 401 individuals have been hospitalized at some point in their illness. Currently, we have 63 Knox County residents hospitalized. That, I think, make note of that. We're at our highest hospitalization numbers since the pandemic began. Unfortunately, we also had an additional death to report today, raising our total to 90. So I'll move on to our benchmarks. First benchmark is sustained reduction or stability in new cases for 14 days. Over this time period, the last 8 days were flagged yellow or red. Our first 4 days presented with yellow flags, followed by 4 red flags. This indicates continued increase in cases and is why we are representing this benchmark as red. Are we good?
It was cached from last week, so we refreshed it to have
Okay.
the correct data.
Okay, thank you. Our second benchmark. Community-wide sustained and increased diagnostic testing with consistent or decreased test result turnaround time. Over the 14-day evaluation period, 4 consecutive red flags were noted for lab lag time. Over the past 2 weeks, lab turnaround time is averaging about 2.5 days. Regarding testing, we did have 3 red flags, but not on consecutive days. Because of these factors, we're continuing to represent this benchmark as yellow. You will notice the numbers on our tests conducted chart have increased. That's because we're now using the Tennessee Department of Health data, which is the data we're also using for the percent positivity rate. So we thought getting those 2 data points in line was important. Sorry, Catherine. Moving on to our third benchmark, sustained or increased public health capability. We currently, with our current epi support team, we continue to be able to initiate investigations in the desired time frame. And because of this benchmark continues to be represented as green. I do want to take a moment just to say, in order for this process to work, we do need individuals and businesses to cooperate. And we continue to struggle with having that, and just anything this board can do and those who are listening can do to help people cooperate with just the basic investigations of our staff would be helpful. Our fourth benchmark, healthcare system capability, remain within current and forecasted surge capacity. During the past 14 days, we have noted a continuous upward trend in hospitalizations for COVID-19 patients. Additionally, over the last 8 days, we have noticed consecutive red flags for ICU hospitalizations and inpatients requiring ventilation. Both of these metrics reflect a continuous upward trend. These flags are based on our published metrics that illustrate statistically significant shifts in the data. However, after speaking with our hospital partners, they have recommended that this benchmark remain at yellow because they are currently below surge capacity and have adequate staffing capabilities for the current number of patients. Fifth benchmark, sustained or decreased COVID-19 related death rate or identified positive or probable cases. Over the past 2 weeks, we have seen 6 deaths, with 4 in the last 7 days. The information available leads us to represent this benchmark as green. However, it is a cautious green because we anticipate this number to increase with the growing number of hospitalizations. And then we have some supplemental data that shows our COVID cases per 100,000. As of today, our 7-day trend for the cases per 100,000 shows about 23 cases per 100,000. And our 14-day trend shows 20 cases per 100,000. And the second chart shows the percent positive of COVID for COVID testing. This is data from the Tennessee Department of Health, and our current average is 9.76, which is at least up from the last time I was up from the last time I did an update. So that is also continues to be concerning. Any questions on the data or the benchmarks?
Thanks, Dr. Buchanan. Any questions?
I have a question. Can we go back to benchmark 4 for just a moment? I was wondering, right underneath the chart, there were some percentages about the beds, and we kind of went past that really quick, and I was wondering if we could take another look at that.
Hold on a second.
Thank you. That's it. Thank you.
Mm-hmm. And if there are questions about this in particular, I may let Dr. Shamia answer them.
Okay. And we're anticipating that to climb.
Well, we don't know if hospitalizations will decline, will increase or not. So you mean available capacity to decline, or what to decline?
Yes, the capacity. You said that it was a cautious. It seemed like in your explanation it went back and forth between red and yellow, ultimately being yellow, but I was wondering if there was hesitation there.
So are you talking about the hospital capacity or the deaths? The deaths were a cautious green.
The hospital capacity.
Okay. So the hospital capacity decision is made in concert with our hospital partners, and they know their capacity and where they are in their surge plans and where they are in their surge capacity much better than we do, and much better than honestly even the numbers do tell us. So it's not just the numbers that we're looking at. We are concerned, and they are concerned about increased hospitalizations for COVID and some increase in ICU bed use. And I don't know, Dr. Shamia, do you want to chime in, or will you talk about this a little bit when you get to your talk?
Yeah, I'll definitely address that when I kind of at the end of my presentation here in just a minute.
So I guess we rely on them because they definitely know their surge capacity better than we do.
Okay, thank you. I really wanted another look at those percentages.
Sure.
Thank you.
Sure.
Any other questions for Dr. Buchanan?
And this, just a reminder to everybody, this data is available on our website all the time to look at, and you can reach out to us if you have questions. My staff are happy to answer questions if you have them.
All right, great. Well, hearing no more questions, Dr. Shamia, did you want to go ahead and do the UT presentation?
Yeah, I'd be happy to do that. So this is really very much the standard presentation. So I did want to start though and frame it in a similar way where Dr. Buchanan just wrapped up. And so next slide, please, is just to initially talk about hospital census, because if there's anything there's a few things that have significantly changed since we met 2 weeks ago. And I'll circle back around to this in a few minutes. But again, this is what we always show. This is the THA defined Knoxville district of those counties. And you see that we're at the time of this snapshot, and census is simply all of the patients in the hospital with COVID-19 on that particular day across all those counties. So it's a real-time snapshot. But you see previously we've been at 185, and there's been a significant steady increase really since that had just started before our last meeting 2 weeks ago. Next slide, please. So this is the new cases by week and by month, like we always look at. And what you see both in Knox County and in the district is this most recent week had a significant increase in new cases, 851 in the county, and then about 1,800 in the district. And again, this is, the numbers may not always precisely line up for the county. This is Tennessee Department of Health data. That's what I've been showing you all along. And so I think the question here, if I was to take a step back, would be to say, what has motivated that sudden increase? I mean, the idea would be that we had more positives potentially because more people got tested. And one possibility there is that a higher percentage of these people were symptomatic and got motivated to be tested, because we know there's a lot of fatigue just being a contact and getting tested or for whatever. So there's the possibility that some level of symptoms may have driven some of this. Next slide, please. So this is that age breakdown that we've looked at for the last several meetings. And so what you see here, we've not had a pickup in the 11 to 20-year-old age group, but there was a significant pickup in the 21 to 30-year-old age group. And then we always talked about if it was going to cascade down into the bottom row. And what you see is a little bit in 31 to 40, a little bit in 41 to 50, but a significant increase in 51 and above 8 years old of those increased cases. And again, it may be symptoms that are driving some of this, if it's increased testing leading to increased positive cases. Next slide, please. So we always look at this as well. And so this just compares us to the other population centers. That Shelby is actually been doing reasonably well here, including kind of on the hospital side. They've seen just a bit of a spike, but Davidson is starting to potentially go up, and then Hamilton is, and we've had the most significant increase of just in this last week or so, but you see the trends. Next slide, please. So this I need to explain, because I think we've shifted to how we may need to look at hospitalization. So this really shows new hospitalizations, and then I'm going to get to that census or the real-time look in a minute. And so there's a disconnect here, and I need to explain why, because this would look like there are not increased number of hospitalizations. But the way this works is this is data that's filtering through the state. These are through the Tennessee Department of Health. And we essentially, what we think is happening here is that contact tracing is driving the process of defining whether somebody was in the hospital, meaning they call somebody, they determine they had COVID, and then they say, yeah, I was in the hospital. So there's seemingly a lag here looking at these new hospitalizations, because next few slides, now we'll look at what was happening kind of in real time on any given day in terms of the number of patients in the hospital. So this was when we last met 2 weeks ago. We had just started to see that increase. And so we were at 129. Next slide, please. This was the week we did not meet, where it had gone to 162. Next slide, please. And this is what you've already seen. which is just a few days ago, that the census or the number of COVID-19 patients in the hospital at one time across all of the facilities in those counties was at that number 221. So certainly a significant increase. Next slide, please. And we do this every week. And so, and I've, made it very clear throughout the time just how much this can change in a week or two, depending on what the most recent data has shown. And so you see just in the last few weeks, green, yellow, and blue, how much the trend line changes. And we've also seen if that starts to plateau and flatten out, that line will come back down. So I always say take that for what it's worth, but it at times has been predictive of what we were going to see in the coming weeks. Next slide, please. So we did look at this. There'd been interest in diving into what is the real distribution of patients in the ICU and in a regular room. And so on the top, that's what we just looked at, really just represented slightly differently. That's the total number of patients in the hospital on each day who have COVID-19. Then the next line is the patients of that total. It's the number of patients each day that were in an intensive care unit. And then below that, it's of the total, the number of those patients that were on a ventilator. And understand that you can be in an intensive care unit on a lot of oxygen, but not necessarily needing to be on a ventilator. And so there are a few points to make here as we just try to understand kind of what's happening. First of all, the blue lines, the overall trend, even though the scales are different, the overall trend looks about the same. And so really what that tells you is that as you get more patients or less patients, it's a pretty steady pattern of a pretty steady percentage of how many of those end up in the ICU. So on a percentage basis, if you look in the middle, it's steady in the 25-ish% of total that are in the intensive care unit on any given day. And then you can also see that ever since the first week of July, that's really been the case. So once we got to a certain number of patients in the hospital, the relationship between ICU and non-ICU was pretty steady. So, I mean, this would suggest maybe some ability to predict that as a percent of total, but it also suggests that it's not necessarily fundamentally changed, at least since the July timeframe, in terms of the distribution between patients who require a regular room and patients who require an intensive care unit. The other point I do want to make is every one of these people who are admitted to the hospital, that's the decision. Many of these are coming through an emergency department, but that's a decision made at the point of care between a patient and a physician seeing that patient. And then if they're to be admitted or the recommendation is to be admitted, then that emergency department physician is contacting a physician in these hospitals to come and do the admission. And then that physician also agrees the need to be admitted, whether it be to a regular room or ICU. So this is at the level of the doctor-patient relationship, is the decision about whether a patient is okay to go home or whether they would be admitted to the hospital. Next slide, please. So to kind of wrap up some key data points, and then I'll speak to where we wrapped up the prior discussion just about kind of the perspective of the hospital systems. But some key points are certainly the inpatient census, which is the number of patients in the hospital each day with COVID-19, has experienced significant growth in the last 2 weeks since we last met. There's also been dramatic new case identification in Knox County, but even more so in the surrounding counties. And that has included that 51 and above more vulnerable age demographic. I made the point that new hospitalization data through the TDH is not correlating because of what appears to be a lag. And so when we have hospitalizations like this, it really seems that the current hospitalization census is a better reflection of what's really happening. Case counts and hospital census is also concerning from our lens in the context of an approaching flu season, student dismissals, because probably these protocols are being followed pretty closely in schools, and then the holidays, which are coming. And then just so to put this in perspective, what we're seeing here, although it's not happening evenly across the state, meaning that at this current time, the eastern portion of the state is seeing this much more dramatically than the western portion, as opposed to what happened a few months ago. But this is happening in spots all over the country, and for that matter, around the world, in terms of increased cases, increased hospitalizations. That's really, I do have a few more comments to make just to wrap up, but I'm at this point wrapped up with the slides. And so back to the yellow-red question, we did have significant discussion among the hospital partners, and we really feel that red should indicate, that should be a significant step, and that should indicate that the hospitals in the region overall have had to have a significant change in how they function, how they operate day to day, related to the total number of patients in the hospital, not just the number of COVID patients, but the total number of patients in the hospital. And that would imply that it means that they may not be able at that point to provide all of the non-emergent services that they otherwise typically and want to provide. So as of today, that has not occurred. And also on their behalf, they wanted me to emphasize that across the board, if you're needing medical care for any reason, you should not let the increase in the COVID census or in the COVID case numbers impact your decision to come to the hospital. We do feel like in the prior experience, when things were completely shut down and people avoided the hospital, that had other effects on people's care. And so, our protocols are strong, and we're partnering together with frequent collaboration, and we certainly don't want the public to get that message. Now, I will say, without question, the hospital systems are watching this growth in hospitalizations closely, and we are in frequent communication. And I know it's been mentioned before in these meetings, and it was even mentioned by Dr. Burks when she came, is that if there's one thing that affects us, it's staffing issues. It's not a space issue when it comes to being able to house more patients, whether they have COVID-19 or they don't. There's a lot of challenges related to staffing in this current environment that are not new, but that are certainly have an impact. And so I'll be happy to, I hope that was helpful. I'll be happy to answer any questions about that.
Thanks, Dr. Shamea. Any questions for either Dr. Buchanan or Shamea? Martha, just a quick question. Just some colleagues that I work with had asked if there had been any, cases or clusters associated with the first home football game. I know folks that actually went to the game, and they said that it actually seemed like a really pretty safe environment. But I figured I would go ahead and ask while we got you here.
Yeah, we don't have any clusters that we're aware of associated with the ball game or any other celebrations related to ball games. That's the
okay, thanks.
data we have.
Okay, thank you. Any other questions?
So can I just add one more thing, is that I did review, so I kind of did a spot review of our cases on a particular day. I made it through about half of them, but I think the question has gone back and forth about, is this incidental? Are these patients coming in the hospital because of COVID-19? Meaning that, and they may or may not have comorbidities, but because of COVID-19, or is it that they're here for some other issue like their appendix, and they just so happen to have been tested and be positive for COVID-19? And in that review, the vast majority of those had pneumonia. So they had X-ray or CT findings of pneumonia that was felt to be, it has a certain appearance related to COVID-19. And we're requiring oxygen, because that's one of the fundamental, now that we have, one thing I will say broadly is we seem to be, the science is advancing in treating COVID-19. And between remdesivir and dexamethasone, which I think people have gotten more familiar with, and remdesivir is only an inpatient medication, we do feel like that's having a positive impact. But really the other thing, even at the level of the New England Journal, is early treatment. And so really, if there's an oxygen requirement, then that's an indication to people who are not normally on oxygen and have pneumonia from any reason and have required oxygen, that's the situation where somebody should be in the hospital. And we do feel like our hospital treatment of those patients has improved as the science has improved in the past several months. So, thank you.
Thanks, Dr. Shania.
I have a
Any other
question.
final questions? Oop, go ahead.
Yes, Dr. Chamia, what's the difference? I mean, when you have pneumonia, you know, it's the whiteout. So what does, how does COVID differ on an x-ray of a lung than normal pneumonia?
So the way you can really differentiate that is more on a CT scan. We always say that I would kind of say, you know, a chest x-ray is more of a general image, whereas a CT scan is very precise. But COVID, and a lot of these patients do get CT scans, has a very distinctive appearance on the lungs of what we call it a ground glass. It's a hazy look that you can kind of see through, not a dense white, but it's in this environment when there's not a lot of other things that can cause that appearance. And quite frankly, when the test turnaround was so poor several months ago, people were getting very good at just looking at the scan and saying that's COVID. And then 6 days later, they'd get the result and it would be positive. But now with our turnaround time being so good, they presumptively diagnose COVID-19, and within hours, they know the diagnosis. So part of it is a very distinctive appearance, and part of it is the positive test.
Thank you.
Mm-hmm.
Thanks. Any other final questions or comments? All right, why don't we move on to our educational institution reports. I believe Dr. Greg is out there somewhere.
Yes. Let me get my video going here. There you
go. Can you turn up your volume? We'll feel a little bit quiet.
Is that better? Is that better?
Can you guys hear him okay? It's a little bit quiet for me.
It's not really, Dr. Greg.
Okay.
You're gonna have to yell at us.
So I'd like to thank the board for inviting us to be with you again tonight. Chancellor Plowman has requested that I speak to you on behalf of the university this evening. First, I'd like to start with our most recent campus case counts, and then update you on recently identified cluster on campus, and finally speak to our broader testing strategy and some of the results that we've seen recently. So I think my slides are available. So our first slide depicts our current active cases. Currently, we have 62 active COVID-19 cases on campus, 59 of which are students and 3 are employees. On our next slide, we have our daily new case counts. As of yesterday, we had 5 new cases reported. And on our final slide, we have the number of students and employees currently in isolation or quarantine. We have 341 people in self-isolation or quarantine at this time. 111 of those are on-campus residential students, 196 are students residing off campus, and 34 are employees. And that's it for my slides tonight. We did identify a new cluster earlier this week. This is our first new cluster in the past several weeks. This cluster occurred within one of our ROTC programs and resulted from several meetings that occurred in preparation for a planned training event. The exposure took place during those meetings on October the 10th, and it was identified by our contact tracers on October the 12th. In an effort to be proactive as part of this ROTC group's planning efforts, pre-event testing had been performed for event participants through the Student Health Center. There were only 2 positive cases identified through this pre-event testing, but there were 26 close contacts, thereby meeting the state's definition of a cluster. Of those 26 close contacts, all had tested negative, and none have yet retested to this time. Individuals required to isolate or quarantine have been identified and will not be participating in the planned exercise. This is an example where if the pre-event testing had not been performed and the positives and close contacts not prevented from participating, then the number of eventual positive cases could have been significantly higher. So we commend the Army ROTC program in taking these steps to be proactive in protecting their participants. We are continuing our comprehensive testing strategies on campus, including our pooled saliva testing of on-campus residential facilities. Last week, we tested 2 residence halls and a number of fraternity houses at Fraternity Park. Of the 671 students participating, we had a total of 46 individuals referred to the Student Health Center for additional testing because they were participants in a positive pool. And 11 of those have had positive follow-up nasal swab PCR testing. We still have a few results still pending at this time. Although over 600 students provided samples, our participation rates were not where we wanted them to be, so we reminded students that their cooperation is required as part of their housing contract and arranged for makeup tests for those who did not originally submit samples. Our makeup test was performed this past Monday, and of the 455 participants, 12 were referred for further diagnostic testing at the Student Health Center. This week, we are testing 2 additional residence halls and a sorority house, and we'll hold another makeup test date for them on Friday if needed. Again, the data I've discussed tonight will be posted at our coronavirus website at utk.edu/coronavirus. The results of our community saliva testing so far have been encouraging, but we can't become complacent. As I mentioned, our participation rates have been mixed and fairly low in some cases. It's critical for our campus that we have strong compliance among our students so that we can act quickly to spot a potential surge before it starts. Our testing is still new and we're learning a lot as we proceed and as we evaluate our results and refine our processes. And with that, I thank you and I'm happy to answer any questions that you might have.
Thanks, Dr. Gregg. Any questions about the UT numbers or testing?
I'd like to just ask one question. Dr. Gregg, are there any incentives that we can get the students to participate more? I mean, it's tough, I know, having had children that age, to get them to participate in something like this, but the numbers are concerning that they are low. And we would really want to encourage the community to get out there and come into the Student Center and Health Center and get tested. But any thoughts?
Well, you know, there's always the carrot and the stick approach. And we've certainly have the stick, and that's through our student conduct. And students are aware that participating in the pooled saliva testing, if you reside in an on-campus residential facility, is required. And it is part of the housing contract that they agreed to when they came this semester. We do have others that are diligently looking into the carrot process and the things that we could do to encourage students to participate. We have to be cautious in the approach that we take with that. There's different ramifications in regard to what we're able to entice them with. And so it would seem easy enough to think of some positive things, but with the university, there's so many nuances to what we're permitted to do and not to do that we have to get further clarification on those. But we do have some individuals that are diligently working, especially benchmarking with other universities to see what they're doing that have helped to increase their participation rates.
Thank you. I hope maybe some discounted pizzas or something else may come along that could help the process.
Exactly. Thank you.
Thanks. Any other comments, questions?
This is Maria Hurt. I have a quick question. I'm wondering, are we seeing nationally the same kind of trend at other universities where initially there was a lot of testing and then perhaps the reality of what that meant in terms of quarantining or self-isolating. And so testing dropped. Have we seen that in other university settings across the nation?
Yes, that trend has not been unusual, especially in universities our size. And here in the SEC, which is where we do most of our benchmarking, many of those have noted the same scenario where as the realization came that a positive test result results in the individual being isolated for 10 days. And then probably the more concerning thing to the individual student is that their friends and close contacts will have to quarantine for 14 days is a definite negative impetus to getting testing performed.
Other questions?
So I had one. I just wanted to circle back on, I believe maybe a few meetings ago, we had talked about the intent to potentially test all the students before they went home for Thanksgiving. I just wanted to see what the thoughts were on that point.
Well, we've actually discussed that with the Tennessee Department of Health, and we've kind of landed on an understanding that we will, and actually tomorrow we'll be putting information out to students in this regard, that we are encouraging them to get tested before they leave to go home, especially during that week prior to the end of classes. The idea has been that we are not going to be requiring students, and quite honestly, even with requiring students, we still don't have that great of a participation in the testing. So we're just simply going to appeal to the students to know what the results are, and appeal to their parents as well to encourage them to have the testing done before they leave campus.
Thank you.
Thanks, Dr. Gregg. Any further questions or comments? All right, hearing none. Thank you again for your presentation this week. Ms. Wagner, did you want to give us an update on Knox County Schools?
Sure. Next slide, please. So this is what I do every week or every other week now, but I want to make a note that this is from last week's cases, because this week is fall break. So we will be updating the dashboard coming Monday, October the 19th. So last week we had active students of 33 and 20 staff. So next slide. So this just gives you a different view. It's a bar graph, and it has the light blue is the students and the dark blue is staff. Next slide. So on October the 9th, we had 220 recovered students, 135 recovered, making a total of 355. Next slide. As before, it's just a different way of looking at it. The light blue is students and the dark blue is staff. Next slide. So the number of students in isolation is 716, and the number of staff isolated is 99, and the total in isolation is 815. And so from the week before, that's really, it has come down quite a bit. I can't remember the exact numbers, but I think it was 1,000 and something, but it has came down. Next slide. Again, this is just a different view of looking at it. And the light blue is the students and the dark blue is the staff. Next slide. If you look at our COVID metrics for October the 9th, the teacher and school staff attendance is yellow, but we don't think it's related to COVID specifically. It was on Friday, and that was the day before fall break. So we think that call-ins and we think that had something to do with it to make it yellow. But usually that is green. Next slide. And these are the COVID metrics, the green, yellow, and red. And I've talked about these before. And these are how we determine when to open this, when to close a school, for a school to go red or to remain open. Next slide. And the only school in red right now in Knox County is Austin East, and it's supposed to open back up on October 19th, unless otherwise notified or indicated. So that's the end of my presentation, I think. If anybody has any questions, I'll be happy to answer them.
Thanks, Lisa. Any questions for her?
Lisa, just one quick question. You know, I know Dr. Gregg talked about their challenges with testing. Do you think that you have families or students who are resisting getting tested because of the consequences?
Yes, absolutely. I've had some parents tell me that, and they don't like being quarantined for 14 days if they're considered a contact. So
nobody does.
Yes, I think that has a lot to do with it.
Other questions?
I have a question, please. This is for either Lisa or Dr. Buchanan. It's actually one of the county commissioners had asked me to ask you guys about flu shots at schools, or you know, what's being done or what will be being done with flu vaccinations at schools.
So do you want to talk about it, Dr. Buchanan, or
Sure,
you want me?
I can talk about it. Lisa, if you want to talk about what you guys are doing with your staff, I don't know what that is, but due to COVID-19, we really didn't think logistically there was a way to do in-school flu vaccines like we had in the past. You bring a whole classroom down, and keeping those kids 6 feet apart going down to the clinic is a real challenge. So what we've been doing is holding community clinics, some of them at a school between the hours of 3 and 6 p.m. We've had several of those with pretty reasonable participation, certainly not as good as we have with in-school flu. We're offering flu mist and flu shots to the family and the children free of charge. So we're doing that. And then in addition to that, we have flu shots available in all of our clinics free of charge to the individual. And so families can certainly come to any of those as well. So we're hopeful that our pediatricians will also be vaccinating. I think we've talked about maybe increasing the number of community clinics we do, because we've had some good turnout, but then we also had some places where there was some confusion about when we were going to be there. But that was our alternative. We've been happy with this. It's gone well. It's been easy, and the families seem to like it because they show up with all the kids, and mom and dad get vaccinated, and so do the kids. So it's a win for the families.
And for the staff, Kroger's came in, they started in September and went to each school and vaccinated the staff. So we had a pretty good turnout for that. And they just finished that on October the 9th.
Thank you.
Thanks. Any further questions? All right, hearing none. Thank you, Lisa. I guess next on our agenda is discussion and trying to finalize our metrics. I think Dr. Buchanan, you've got that?
Yes, I do. Yeah, so if you want to pull up, I don't know, which one is that? Is that the old one? Is it the one they've seen? Okay. So after I got back and so all of you all saw this 2 weeks ago, correct? I'm sorry, since I wasn't here. No, okay, so you saw this 2 weeks ago, and after I reviewed it and talked to Roberta Sturm, who is available if we have questions I can't answer, the one recommendation I made, so Catherine, if you could scroll on through down to, well, actually just this table. The one, if you recall previously, if you look at testing volume over in the escalation bar box here, this was 7 days. So averaged over the most recent 7 days. And all of these 28s were all 7 days. So Bert and I talked about it, and using 28 days gives us more stability because we're looking over a longer period of time. And so we have more assurance that that number is real and not the result of one day that's just been high or low. And it's also consistent with what we were doing with the recession bar. So unless somebody has an opposition to that, that's the only recommendation I made, and certainly happy to hear any discussion about that recommendation. And I'm happy to go through this if anybody would like me to. Again, if anybody has questions, again, Bert's here. So if you'd like, would you like me to run through the slide presentation, or do you want to just to have a discussion about setting the metrics?
Do you have the slides changed to this escalation barrier, the 28 days? I'd love to see that.
Yeah, it doesn't, they really don't change very much, but yes, we can run through those. So our first, go ahead and go to the next slide. So our first metric was testing volume. So we want to see 1,700 or greater tests that averaged over 28 days in order to move things or take things away. And then escalation would be less than 750 tests a day, averaged over those 28 days. I have some questions about what we do in between the escalation bar and the recession bar that I think we can have after we go through the slides. And if you look at the kind of orange looking line, this one, that's the 7-day average, and this is the 28-day average. So you can see there's a little bit more variation in the 7-day average than there is the 28-day average. So we felt like that was a more steady state to get to that steady state and be able to say, okay, we're good here, let's make a change. Next slide, please. So again, positivity rate, looking at, taking things away at 3% or less, positivity rate over 28 days, and changing things in a different way, putting more things in place at 5% or greater over the most recent 28 days. These numbers are both recommended by Harvard School of Public Health in one of the studies that they had. And again, you can see our current situation. It's been quite a while since we've been below that 3% bar for positivity rate. And we've been above the 5% bar for quite some time as well. Next slide, please. So number of new cases, again, recession bar, 3 new cases per 100,000. And if you remember this evening when we talked, right now where we are is we're at, where to go? We're at 23 cases per 100K for the 14 days. I'm sorry, for 7 days, and 20 for the 14 days. So we're above both of these right now. And again, you can see the difference between the 7-day trend and the 28-day trend, just a little bit of stability there. Next slide, please. And then this is the regional hospital census. Again, having averaging 100 patients over the most recent 28 days would be a reason to increase, and 50 patients over the most recent 28 days would be a reason to lift something. And basing this on the district rather than just Knox County, it just makes sense. The district impacts Knox County so much, and many of those folks come here for the hospital. And so they impact our hospital census and our hospital surge capacity. Next slide, please. So next steps. So next steps are to approve this or make a decision to do something different. I did have a couple of questions after I looked through this, and not having been here last time. One of the things, positivity rate, as we've talked about, is very dependent on testing volume. At our current testing volume, you question whether more people who are sick are getting tested because they get sick and go to the doctor. Our testing volume has gone up a little bit this week, so that's encouraging for just walk-in testing. But I think that's one thing that we'd really have to emphasize to the community, that positivity rate is very dependent on testing volume and can go up and down depending on who you're testing. And then I guess the other question I had is what does the board think that escalation looks like? You know, what would the board do next? I mean, we're well above all of these things that we're saying we might set as metrics. And so we have a mask mandate, we have a bar curfew or closure in place, and a limit to crowd size in place. What other steps would we want to take as an escalation? And how realistic are those? How well tolerated would those be, and what would be their impact on our economy and our community and the psychological and social well-being of our community? And so that's just, those were a couple of the questions I had. I also know that you asked that I look at West Virginia and Shelby County, and excuse me, I did look at West Virginia, but wasn't able to talk to anybody there. And just looking at their website, I couldn't really tell. The only thing it looked like they were using was, excuse me, positivity rate and positivity rate and new cases is all they're using to determine whether a county is green or red, and they're using that statewide. If we broke that down for the county, would we use it by zip code, or so it didn't seem to be something that would be any more helpful than what we have. And then I looked at Shelby County, and they are using some very specific benchmarks, but honestly, one of them was having an average case number of below 180, and that we've Bert, correct me if I'm wrong, have we maybe 1 week we averaged more than 180 cases a day? I mean,
I think we've only gone above 180 cases a day a handful of times.
Mm-hmm. So, they're also, in a different situation. They have a larger population. So anyway, those are my questions. Happy to have discussions about that and hear what your questions are. But I do believe if we're going to set some metrics, I think we've been talking about this for a while. So I think we need to do it. But if we're going to set metrics in place, we should use them.
Thanks, Dr. Buchanan. So I think 2 weeks ago, when you weren't able to be at the meeting, we did discuss the 3% and 5% positivity rate. And is that even realistic for us to achieve? Just looking at what's happening right now. I think, was it maybe Dr. Shemaya that brought that up? I don't know if you wanted to reiterate kind of what that discussion was.
Yeah, no, I'd be happy to. Actually, I have, guys, this is, I think, important work, and a thoughtful pause here a little bit, and some discussion is important. And so one thing I'll say is, Dr. Buchanan, there at the end, you talked about a lot of different things. And so to try to focus on the metrics in and of themselves, I think it's easier for me to think about what the recession cutoffs might be to loosen restrictions, as opposed to this much bigger question about escalation and what would that even look like. And so I guess I'd like to start there a little bit. And it may be most useful. Could we put back up the table? I think if we're not looking at it, it may be hard to have the conversation, what Dr. Buchanan had started with.
Just a moment.
Yeah. And so
stepped out, but we're taking care of it.
Okay. Because I've given this some thought about, first of all, the specific ones that are there. And when you think about, there's really no plan or approach that doesn't include new cases per 100,000 in positivity rate. I mean, those are very, very common. And then we talked about something related to hospital census being kind of a backstop for this. And so I'll address that separately. The one that as I thought about it, I think is harder and is more of a difficult one to pin down is testing volume. Because we know that we're not hearing about necessarily every test that is done, and testing volume is inherently part of the positivity rate. And so, for example, if it's only sick people going to get tested, that's not what you want. That's not how you control, from a public health perspective, a pandemic. But if you have a mixture of sick and the contacts and whatnot, then that's how it is controlled. And so I almost think positivity rate and testing volume are a little bit redundant with each other. And so, Dr. Buchanan, I guess the first thing I wanted to ask before we kind of get to Dr. Souza's question of the 3 versus 5 and those type of things, because I do have some thoughts there, is how strongly do we feel about including testing volume as one of the 4, or versus just having 3?
Or I'll let you take that because we talked about it. Or I can take it.
Well, I was just going to suggest, one thing that I could do is take testing volume and positivity rate and include that as one, where we have positivity rates maybe overlaid on top of testing volume. So that way maybe it's a little bit more clear on how many of those tests are actually positive. I don't know yet what that would look like, but that is one suggestion.
Okay. So that's something for us to think about. Then I guess as we get to that other point about cutoffs, it gets to how exactly would we use these? And I think that we have to be very cautious about, I mean, we understand this environment well enough to know that absolutes it's very difficult to set absolutes with anything. And so I guess the question is, and that's my opinion, but are these kind of firm guidance, or are these meaning that they're non-negotiable at the point of when we hit certain things? And that would go for escalation too. We can't talk out of both sides of our mouth. Or is it just trying to be a more well-defined set of almost a very well-defined entry point for the discussion, meaning that if everything lined up and we weren't going to follow it, we better be able to justify why we didn't, which would be really more specific than what we've been in the past. And the reason why I bring that up is, for example, 3 new cases per 100,000 and 3% positivity rate. If these were more of an entry point, I would be more comfortable, and I think it's more realistic that those would be 5 and 5. 5 new cases per 100,000 and 5%. That's not quite as strict as what most public health policy guidelines would indicate, but I think it's more achievable and more realistic. So Dr. Buchanan, I guess I'd start with you and then open that for general discussion.
I'm not opposed to that. I think these numbers are low. I think that achieving some of these numbers are low. They are from the part of the White House recommendations. So that's where these came from. And so that's just one of the things to think about. None of this is set in stone. This is for the board to discuss and decide. So
comments or questions from others on any of these?
Dr. Souza, I guess the question would be, in the context of recession, is how exactly are we going to use these? If we don't have that understanding when we set some numbers, then it may even guide how we set the numbers.
Right. Yeah. So I guess thinking along that is, okay, so if we get 3 of 4 that are recession, can we drop one particular thing, but not everything? And the same idea in the reverse, that if we have, reds, everything is in the escalation range, what do we add on top? We don't want to go there, but agree that, do we have to have all 5 before we take something away, basically? Thoughts from others?
I'll just throw out that, I agree with recession barrier of like 5% positivity rate and 5 new cases per 100,000 sound reasonable. I think we should use these as guidelines, not hard, fast. Okay, if we hit these, then we have to make a change. I think we have to use this information plus other pieces of information to make decisions. I'm most concerned on the escalation part. Right now, with our numbers going up, it's difficult for me to think through escalations of mitigation efforts that we would put in place that would be met with success in our community currently. So I think that's something we need to talk about. And I would, again, just set these as guidelines for use, but not hard fast so that the public thinks, oh, we hit, like you say, we hit these greens, 3 of, let's say 5, and something has to happen. I would say that we need to talk about it and use as data points to help make decisions.
Other comments?
So I do want to discuss the hospital piece of that, but I don't want to distract us prematurely from positivity rate and new cases. So Dr. Souza, just let me know when you feel like we've transitioned to a point where I should discuss that a bit.
So I just have one, so just taken a minute to kind of think about it and maybe simplify things. I think you're right. I mean, testing volume and positivity rate are very connected to each other. And I'm not sure it's useful to have both on there. So if for simplification, we certainly could drop testing volume. Positivity rate does tell us a little bit about testing volume because like Dr. Shamia said, the smaller pool of people that are getting testing, the higher your positivity rate is going to be, probably because you have fewer people and more of those people are going to be positive. I also agree with not using just one of these to say we're going to do something. The one thing I thought about was, the thing that probably is going to be the last thing that we would change is the mask mandate, to be honest. And so, things in between, when we're in between the green and the red bar, what are the things that we could let go of that would be give the community some relief? That would be reasonable. So that's one way to look at it. It's kind of like our other metrics. We're really not using one piece of information to provide guidance and make decisions. It's all of those things combined.
So, Dr. Buchanan, if we change those to five new cases, 5%, though, I mean, at that point, is there really much between? To me, there's not a lot happening between the green and the red. If we change those to 5 and 5, then to be comfortable with recession, you need to be in the green. I guess my question was the 28 days also, because I mean, you could talk about doing that for a shorter period of time. The idea of doing it long is that's reliably that tells you that it wasn't just a 5-day blip or a 7-day blip. You have reliably fallen to a positivity rate below 5%. But I guess my sense is if we were to change those as 5s, again, as Dr. O'Brien said, not absolute, but as pretty decent guidance, that there wouldn't be a lot of going on between getting below the green barrier and then hitting the red barrier. So what do you think about that?
No, I think you're correct. But I guess if you change your positivity rate to 5 for the recession, should you not also change your escalation?
Oh, I see. I see. Oh, yeah. No. As I said in the beginning, I'm trying to put escalation, put it in the corner for a second and just focus on recession. I see what you're saying.
So I think, 5 new cases per 100,000, I think is reasonable. I realize that some of these numbers did come from the White House report and the White House recommendations that I have right over here. So that's something to think of. Again, I say that based because those are also being used across the country as standards.
I understand.
Yep.
Go ahead. Sorry, Dr. Susan.
Well, no, I was going to just say, if we're looking at kind of a ratio of, basically at least for the new cases, is about threefold increase. And so if we went up to 5, would it make sense to go up to, 15 or 20? And same thing with positivity rate, just to at least keep a similar ratio in terms of what we're looking at.
Bert, want to chime in on that?
Yeah, so right now, if we did 5 new cases for the recession barrier, that's roughly about 20 cases. And so then conversely, if we did the threefold times that, like you suggested, that would be what, roughly 90 cases. And I think, even last week, we were at about an average of about 80 something cases before we saw this increase. So I don't think that's unreasonable, but that's kind of where what we would look like.
I guess my thought was that to make it straight simple, but Dr. Buchanan, please push back on this. But if recession was 5% and 5 per 100,000 and escalation was 10% and 10 per 100,000, then it's 5 and 5 and 10 and 10. And understanding we haven't had the conversation about what escalation really looks like, but that, or if there is even escalation, but that would be one clean, simple way to do it.
I don't have any, processing numbers live and in person is a challenge. Bert's much better at it than I am.
No, I understand.
I feel like, if we move the new cases per 100,000 up to 5, and that's just what's the margin there, Bert, for between 5 and 10 cases per 100,000?
That would be, let's see here, 10 new cases per 100,000 would roughly be 50 cases a day, I believe. If I forgot my population right. And then, it would be between 5 you're looking at more like 25, 10 would be roughly 50. And then if you did the threefold, as Dr. Souza said, then that would be, what did I say?
About 75, wouldn't it?
75.
Yeah.
Something like
Thank
that.
you. And I think one important caveat to this is that would be outside of any known clusters, because one thing that we saw early on in the pandemic is we did have some clustering with maybe a specific type of work or something like that. So I think, having that caveat in there stating that it's outside of a cluster, these are independent cases. So I think that's kind of important to note.
Can I ask a question about just on the testing volume aspect, with additional resources supposedly being pushed to each of the states? If we were able to get our citizens to participate in, almost like testing days or things like that, to get our numbers up so we could see what our true positivity rate is in the community. As you say, what we're getting right now are more sick people who are getting tested, and I don't think not as many asymptomatic. So I don't know if it's worth, our efforts to do a broader based testing strategy if we have access to quicker tests, and I don't know if we do yet in Knox County, to help drive a more realistic number. I'd love to see as many people tested in the county, thereby getting a true positivity rate, which I think would be much less than what we're currently getting, hopefully. Just your thoughts.
Well, sure, it'd be great to increase testing volume. We've done community events targeted at certain areas of Knox County, and we've had mixed turnout and mixed participation. So, it's how do you drive that participation, and how do we have enough people to get that done? Realistically, I'm not sure we can do much more testing than we're already doing in the community. We're testing every day from 9 a.m. to 3 p.m. here at the health department. It's free. You don't have to have an appointment. And we're also hopefully not doing the majority of the testing. So that, you have private physicians who are testing, who we know have been limiting who they test because they're not getting paid to test asymptomatic people. So that's another challenge. So certainly would want to talk that over with my staff, because I think it would be hard to get private docs to step into that arena. I think it would fall to those of us who can do those things for free. You know, our turnaround time is better. We are working our staff 7 days a week. And so I'm not sure, kind of like Dr. Shamia, one of our challenges becomes, it's a great idea to do some more testing, but who's going to do it? Staffing becomes one of the challenges.
Yeah.
And honestly, community uptake becomes one of the challenges.
One thing I'll just throw out is possibility that kind of seen is where you use people like where I come from, the National Guard, other organizations that could be brought to bear on like a named 2 Saturdays in a row, everybody that can by the name in the alphabet you get from 9 to 10, 10 to 11 is a different part, and have certain big areas where it's easy to access. I don't know if that's possible. I don't know if we have the resources to do it. I don't know if we have the test available. That's the big thing, just having the test that we can do. So just again, something to think about.
Sure, we can think about those things.
Dr. Buchanan, do we have any drive-through testing in Knox County?
We're not doing any drive-through testing anymore, but for several reasons. It takes a lot more people to do drive-through testing. We're doing a very little drive-through testing. We're still doing some, but it's very limited. But it takes more people to do drive-through testing. There's more risk involved in drive-through testing. And when it was 90, 100 degrees outside, it's hot in PPE, whether you're inside or outside. And so we made the decision for staff safety that moving testing inside was a better idea. And people, I mean, it's walk up, it's walk in. You don't have to have an appointment. There is a short registration process, but our put through is pretty good, and we're able to get people through, I think, more quickly than we were at a drive-through. So we're happy with that.
Thank you.
Sure.
Further questions or comments on the first 3, I guess, before we talk about the hospital? I guess I'll just kind of agree with, I think there is a little bit of redundancy between the testing volume and positivity rate. I think they obviously both have value, but if we're trying to reduce, I don't know that we necessarily need the both.
Okay. And I'm fine with the 5 and 10 and 5 and 10. I'm fine with that. Those metrics, I don't think 10 versus 15 makes that much of a difference. So to change the positivity rate to less than 5 for recession and greater than 10 for escalation, and then 5 new cases and 10 new cases for the new cases piece. If ever, I mean, I'm okay with that. And Roberta says she's okay with that too. And it's important, and I keep referring back to her, but I think it's important that my epidemiology expert is comfortable with the metrics that we set.
Agreed. Any other questions on those first few or comments? All right, Dr. Schmidt, you want to take the hospital metric?
Yeah, no, thank you. So one thing that I think we've determined in the last few weeks is that the hospital capacity is potentially even a moving target. And what I mean by that is that the variation in staffing, and when I talk about staffing, I'm talking not just kind of day-to-day staffing, but even surge staffing. And so something as simple as a cluster among a group of nurses could take a nursing unit and make it where it couldn't, in a short period of time, have patients, and then 10 days later, they could have patients again. And so there's a lot of moving pieces to that. And so what I kind of sensed in the discussions between the hospital systems is that, I mean, I think they're going to be talking about yellow and red. And honestly, what I also have a sense of is there's 2 types of yellow. there's yellow that's rising and there's yellow that's falling, but it still hasn't fallen below a certain threshold where we feel like everything is just back to normal business with nothing to really be thinking about. And that's where we were over the last several weeks. I mean, today we're yellow, but we're clearly rising. But then for several weeks, we were yellow and dropping. And so when I look at these specific numbers, and to be able to say that, yeah, those are right, and those are the ones that should play into this, versus whether we were yellow and rising or red versus green or yellow and dropping. And so one thing, Dr. Buchanan, I know you were not here last week. I mean, this has been a very robust discussion today. And I know you have a desire to kind of wrap this up, but if we've not had this depth of discussion on this before, and I don't think we're at a point where we're hitting really hardly any of these right now. And so if we needed another week or two to finalize these, I don't think it would be the worst thing that ever happened. But I guess what I'm saying is I don't know how comfortable I am with a specific number related to the hospital census, but I am comfortable after the discussions we've had over the past few weeks that yellow dropping versus yellow rising, and even a better idea of what red is going to look like. And so one alternative would be just to put those things in there. I know those are not the hard numbers that we're trying to for everything else, but at the same time, the hospital situation is so dynamic. So be happy to take any questions, or let me know if that makes any sense where I'm headed.
So it makes sense. And that is long ago and far away, when we first brought this up, I really recommended that we base it on our benchmarks and seeing improvements in our benchmarks. And so I don't know if we want to add some language in there that kind of takes into account the benchmarks and where they are, that, we're seeing improvements in those as well. These things are all reflected in our benchmarks, so I'm okay with that. But it is nuanced. It's not, picking hard and fast numbers is really hard, is really challenging. And if you need to take this back and even discuss it with the regional hospital folks, I'm fine with that. And yes, I know I expressed a desire to make this happen, but I think you're right, we're having a good discussion. We haven't really had that. And if you need to take it back and run it by your folks and talk about what a hospital indicator would be for making a change, I'm fine with that.
This is Ani Roma. I have a question about that then. Does the fact that our hospitals serve citizens from outside of Knox County come into play at all here then when considering those numbers?
So, Dr. Buchanan, I think you said that by using the THA region and Hertz, and of course we have some hospitals that are located in Knox County, and then some of the systems have hospitals outside of Knox County, but it's really all the hospitals serve all the patients in the region. And so I think this captures that very well by where they're pulling the data, that it would be artificial just to say hospitals in Knox County are hospitals that are just looking at Knox County residents. This really looks at the healthcare system in our region. And of course, it probably very significantly serves the patients of Knox County, but it also significantly serves the patients in the outlying region.
Okay.
I hope that answered your question.
Got it.
Further questions or comments? And, I agree with the idea that even if, we were to adopt this tonight, as we've discussed, that we're well above any of the recession barriers that we've put in place. And so I think it does make sense that if Dr. Shamiya could reach out to some of the other regional hospital partners to see, what really makes sense when we're looking at the hospital capacity. Do we just stick with those benchmarks that we've got with the red light, green light, yellow light, or is there numbers that we should put to that? Other comments from anyone?
Just so I know what to take back, is the concept of stratifying yellow into two, yellow rising and yellow falling. Does anybody have any fundamental opposition to that if we went in that direction?
I like it. I think it'd be very helpful.
So it's really just the concept of trending.
Yes.
Well, trending, and then there would be some absolutes along the way, probably.
Okay, thanks. Any further questions? So I guess at this point, do we want to plan on revisiting this in 2 weeks at our next meeting? And hopefully we can have some more information regarding the hospital system and how best to include that in these metrics.
Yes.
And I assume we'll move forward with, as we discussed, it seems like there's a consensus about the 5 and 10 and probably dropping testing volume. So that's my assumption here. Am I correct?
That seems, I don't know that we necessarily need to take a vote on it, but that seems to be where the discussion went. And I guess perhaps next week or in 2 weeks, if we have it closer to a done, we could potentially vote on adopting them. Any final discussion? If not, I guess we could move on to agenda item 12. And I guess if everyone would allow me, is taking the privilege of running the show this week. I just want to share a manuscript that came out on Friday in the Morbidity and Mortality Weekly Report, which for those out there watching, this is a peer-reviewed journal that comes out from the CDC. And if it lets me share my screen, I'm going to try to do that. There was a study that actually came out from, hang on, got too many screens open. There was a study that came out on Friday, and what this study was actually looking at, hopefully you're seeing trends in COVID-19 incidents after implementation. And what they were basically doing is looking at seeing what happened in Arizona after a number of measures were put in place to try and reduce the incidence of COVID-19 disease. And basically what they found is that they work. And so there was a variety of, mask mandates, bar closures of gyms, across the gamut. Some of it looked sort of like when the stay-at-home order was in place. But I can scroll down just so that everyone can appreciate the great epi curve down here. That's got, scroll all the way at the bottom. That really is showing, what happened when the virus first basically showed up in early March. And they had put various things in place, and what happened is these eventually led to a flattening and then a reduction of the incidence. And so just some evidence that, we're starting to have the research show that the public health measures that are being put in place actually do work. And I encourage anyone, and I'm happy to share this with the board, I can send the link out after the meeting, but to just take a look at some of the research that's actually coming out of various institutions, but certainly the CDC is putting a lot of research out. And then just one other comment I wanted to make, because I saw that we got a few emails today in our Board of Health box that people were concerned that they're going to polling stations. Today was the first day of early voting, and they're concerned that masks were not required. And correct me if I'm wrong, but I think we had that discussion back when the mask mandate was put in place, and Governor Lee stated that we could not include polling places in the mask mandate. Is that correct? Mr. Sanders,
I don't know if it's from Governor Lee, but yes, we could not include polling stations in the mask mandate because they are technically a government location when they're a polling station. So they don't fall under the jurisdiction.
Okay, and that's what I thought. I just wanted to clarify that, so that if anyone, unfortunately, we have no power over that. Taking my liberties. So I guess the first Discussion is on 2020-1, which is the face covering mandate. Do we have any discussion, questions, comments about it?
I want to make a comment. I did do early voting today, and everyone wore masks inside and outside, and they were social distancing at Downtown West.
Thanks, Dr. Drake. Good job. Any other comments or questions? All right, hearing none. The next one up for discussion is 2020-5, which is our curfew on establishments serving alcohol, which I believe is due to expire, I believe tonight.
Tomorrow.
Is it correct? Or tomorrow.
So it would need to be renewed.
Yeah, so we would need to actually renew this, otherwise it will expire. So
So
I'll open up discussion or comments from Dr. Buchanan.
the report from my staff and mostly the city, we've had 12 complaints about bars being open after the curfew. We've reached out to those folks and educated them. And then KPD, Knoxville Police Department, has had 9 complaints. And again, they've only done education. There have been no no citations issued. Nobody's been closed for not doing this right now. They're still really trying to educate. There are certainly repeated complaints about the same locations. And I think if we look at the numbers, certainly we don't want anybody to ignore our recommendations and regulations, but out of all the bars and restaurants in Knox County, if only 11 of them have complaints, I don't think that's too bad of a report. I think most places, again, are complying and wanting to keep their patrons and the community safe.
One thing to note is our order was an 11 p.m. order, and there's only a very small number of businesses that stay open after that time. So, I mean, that's one piece of this. I'm just doing a survey of looking at closing times across the community. There are very few places out of our, hundreds to thousands of restaurants and bars that stay open past 11. So it is a very small number that we're talking about this time.
And can we just make a note to encourage folks to continue to dial 311 if they do observe somebody in a business in violation, because even though it's just a few, those few do undermine all the other businesses who are really doing their very best to practice safety measures.
Thank you, Ms. Roma. That was one of the things I wanted to bring up. Folks have been emailing us about their complaints. Really, they need to call 311, whether it's in the county or the city. 311 will route that to the right group to follow up. And actually, you'll probably get faster action by calling 311 than emailing us, because I have to forward it to one of my staff members who then has to follow up on it. So get better service by calling 311.
Further discussion?
So to follow up my presentation and to put that in a little bit of context, when we met 2 weeks ago, we had talked about how we'd had the significant spike in cases in that younger population, and we weren't sure to what extent that was going to translate into the sequential effects that stagger over time to hospitalizations and whatnot. But I will say that if you had asked me 2 weeks ago when we met if we would see that census number of 221, I would not have predicted that. And so that does give me, meaning I would not have thought it would be that high that fast. And so I do think that we're in this period where the testing or the community's desire to test, I mean, there's fatigue and whatnot. And so our ability to use that data not only are we where we are today based on what I said, but our ability to use that data to predict what it's going to look like in 1 or 2 weeks, when it's going to plateau, how high it'll go. I think we're more in a period of time of we just need to follow it and see. But I just wanted to put this and then the next, the social group transmitted, to put that in context, is that I didn't think we'd be where we are today. And so I'm not willing to say where we will or won't be in 1 or 2 weeks. And so given that, it would seem that that's something we need to really be keeping a close eye on in the context of the public health policies.
Thanks, Dr. Schmay. Yeah, I kind of share your worry that over the last week or so that our case count keeps crawling up, and in 2 to 3 weeks, are we going to have even more people in the hospital associated with those?
And the question is, what are we going to do as a board? It's not appearing that what this 11 p.m. curfew, unfortunately, doesn't appear to have made much dent in this hospitalization rate. But is that where we have the issue? Is it, as we have talked about before, and I haven't talked to staff today, is it still personal gatherings, at homes, in the park, other places where people then get this and spread it, or is it at restaurants and bars? So I don't know the answer at this point, and I'm not sure. I'm reticent to discontinue something, but I'm trying for us to think, what can we do to help this number, this continuing escalation of hospitalizations? And I don't know the answer right now.
I will say that, looking at case investigations, our reports mostly are in the clusters that we have are around social gatherings, not around bars and restaurants. But, we made this decision based on data from other locations where they had similar things in place. Arizona was one of those places that did help reduce the number. So, who's to say we wouldn't be worse if we didn't have it? I don't know. It's hard to say. But we continue to see folks, just be human, getting tired of the regulation, feeling weird about having a mask on when I'm at a party with a bunch of friends, or somebody's baby shower. And that's what's happening. And people are getting exposed, or, people just having casual gatherings and not thinking about it and getting exposed, or meetings at work. You heard about the National Guard event, or the ROTC event, or whatever it was at UT, not National Guard, where, and we see a lot of that, where they have a meeting, and again, maybe they're 4 feet apart, or they're not quite 6 feet apart, but they take their mask off, and we end up with a case or two, and all of those folks are contacts. So that's primarily what we're seeing.
Help me out. I'm still new. If we vote to extend these, would they expire in 28 days? How long would that extension be, or renew?
It would be as long as we want it to be.
Yeah, so that'd be up to us. Yes. Sorry, go ahead.
One thing, how far out does the governor's emergency declaration go? I can't remember.
I think through the end of October, doesn't it? I believe.
Yes, it's my understanding.
So I guess the question is do we want to extend this through the end of the month or not? Obviously, we're seeing increased numbers. Would they be worse without it? I'm not sure. The study that I mentioned earlier from Arizona, most of what they did that led to a drastic increase was actually completely closing bars down. I'm assuming that most of us probably don't want to go that route. But what is the right route to go?
So I'll make a motion based on significant rise in case counts and hospitalizations to extend for 2 more weeks as written.
I second.
you have any further discussion? Hearing none, Narda, could you do a roll call vote for a 2-week extension of 2020-5?
Thank you. This is Nora Capitelli. We're taking a vote. Dr. Drake?
Yes.
Dr. Gutcher's not here. Dr. Hurt?
Yes.
Mayor Jacobs?
No.
Dr. O'Brien?
Yes.
Ms. Roma?
Yes.
Dr. Shamia?
Yes.
Dr. Sousa?
Yes.
Ms. Wagner?
Yes.
And Dr. Buchanan?
Yes.
Eight to 1. Passes. Thank you.
All right, thank you, Narda. Next for discussion is, I guess, very much tied to the last one, is 2020-6, which is the group size suppression.
Does that expire tonight also?
Yes, ma'am. Yes, it does. Oh, they're on the same timetable.
Make a motion that we extend it 2 more weeks, the same as.
All right, I believe that was a motion by Dr. Drake to extend 2020-6 by 2 weeks. Is there a second?
I second.
Any further discussion? Hearing none. Narda, can you do a roll call, please?
This is Narda Capitelli. We're voting to extend 2020-6. Dr. Drake?
Yes.
Dr. Gutcher's not here. Dr. Hurt?
Yes.
Mayor Jacobs?
No.
Dr. O'Brien?
Yes.
Ms. Roma?
Yes.
Dr. Shamia?
Yes.
Dr. Sousa?
Yes.
Ms. Wagner?
Yes.
Dr. Buchanan?
Yes.
Okay. Passes 8 to 1. Thank you.
All right, thanks, Narda. Next on our agenda is setting the meeting schedule for the rest of the year. And this came up because I think a few of the folks maybe at the health department noticed that. So our next meeting is scheduled for October 28th, which is should not be a problem. The meeting after that is scheduled for November 11th, which is Veterans Day, which I believe the county is closed for. They notified me. And then the one after that is November 25th, which is the night before Thanksgiving, which might be a little bit challenging for folks to make. So there was I guess the thought would be, could we do one October 28th as planned, and then have one on November 18th, which would basically give us 3 weeks between those, and then start up our 2 weeks again after that.
So, Dr. Sousa, can I kind of broaden that discussion just a bit?
Sure.
Particularly when you mentioned a 3-week gap there, I alluded to this a minute ago, but I was the one that, I've been I got us meeting every week, then I got us meeting every 2 weeks. And quite frankly, I was surprised at how much the situation changed in 2 weeks. And I honestly, I think there's a lot of benefit to meeting every 2 weeks. And I still don't think there's any policy that we would enact for less than a week. But at the same time, what it has shown is that the potential that we will walk in from a data perspective to a big surprise or a dramatic shift in what we saw before. And so, and I just mentioned a minute ago, I really don't know what it's going to look like over the next 2 or 3 weeks. from a case count or hospitalization standpoint. It's like every chapter of this, it writes a different story. And I think we have entered, it's a new phase where looking at what happened in July or looking at what happened in April is not necessarily going to be particularly reliable to tell us what's about to happen in the next several weeks. And so we just have to accept that if we're going to go 2 weeks, and I'll be honest, I'm a little bit uncomfortable going 3 weeks, that we may walk into a significantly different situation. One idea is that I know the county commission, I believe Mayor Jacobs, they meet once a month, but then they have a more limited agenda work session. And, you know, one thing we could do is be very intentional and have, you know, if we went back to a weekly cycle, have the, you know, make it a short agenda with the intent of really just looking over things and discussing things without any votes, other than if we have to vote on an agenda or something like that. But another thing I've realized is in the last 2 weeks that it appears that this Board of Health meeting is one of the main mechanisms of information dissemination to the community, because there hasn't been a lot. We weren't there for a week, and that yet there was a lot going on in the last 2 weeks from a COVID-19 standpoint, and maybe thankfully, because everybody needed a break, but it didn't really, I mean, what we're talking about tonight probably is going to be a surprise for some people. And so I don't have a strong opinion other than I do not think we should take a 3-week break, but I thought it would be worth discussion.
Okay, yeah, and the intention would not be to permanently go to every 3 weeks. I think it would only be for those 2 where we're running into holidays. And so I don't know if there's an option to do it another night that week that would not be a holiday. That's not Veterans Day, that week of November 11th meeting. I guess I would have to work with the county folks to see if that's actually an option. And the same with potentially, I would imagine, but I don't know if, you know, I think that when we set these as Wednesday nights, this was the best night for everyone's schedules for whatever reason. And so I don't know if, you know, October 28th is on the books and that's fine. You know, could we deviate to a Tuesday night that week and so do it November 10th instead?
This is Maria. Here's what came to mind. First of all, I agree. 3 weeks makes me, I'm anxious about a 3-week gap. But what came to mind, and this may not be palatable to anyone, but you know, if we met on the 28th and then we met again 1 week later on the 4th and then resumed our bi-weekly meeting, and that would avoid the 3-week gap. The price, you know, everything costs. So the price would be that we'd have to meet, you know, 1 week later. But again, we don't know what could happen from week to week. And there's no way of predicting whether that would be the critical week that we really wish we'd met anyways. But if we meet on the 4th and then the 18th of November, we stick to Wednesdays. I think changing it to a different day of the week, even if it was convenient for all of us, I think consistency for the community's sake is helpful. So anyway, I'm just throwing that out. We would have to kind of double up, resume back to once a week, just one time. But I think that's, in my mind, it's better to err on the side of caution and meet one time more frequently than have a longer gap of time.
So I will say, we always have the option of calling an extra meeting. We always have the option of calling an emergency meeting, or, you know, the chair can do that with a 48-hour notice. So that's an option. So, you know, that's something to think about. And I'll be honest, I can't answer any of these questions about availability of CTV and stuff like that tonight anyway. So I've written down several different options here. Moving it to the Tuesday before, thinking about doing November 18th, or maybe doing a meeting on November 4th. I mean, to me, the evening of Thanksgiving is not that big a deal. People might be out of town, but if they're out of town, they're out of town. You know, we're here, we're open. I mean, my staff is probably gonna shoot me for saying this, but you know, this is our job and we're available and we're here. So I don't see any reason to change that one. Folks who go out of town or aren't here, we will, you know, if we have a quorum, we can meet and vote. If we don't have a quorum, we can meet and not vote. So I don't see a reason to change that one. So I think Veterans Day is a bigger deal. I think allowing my staff to have that day off would be nice. So I can look at these other dates and come back in 2 weeks or with some possibilities, and then we can decide then. Because we've got, that's almost a month away. So
Does the governor's executive order expire at the end of October for electronic meetings, virtual meetings?
As of right now, I believe it does.
if he doesn't extend it, then there's just discussion item also, or for other business. I just want to mention what County Commission is considering regarding changing the ordinance related to the health Board of Health, sorry, as well, which might impact our ability to do virtual meetings also.
Okay, so I guess Dr. Buchanan, you'll look into those couple options and we can decide next time.
Yes.
Okay, perfect. Thank you. Agenda item 14 is letterhead approval. By far the most exciting thing on the agenda.
It is. Very excited.
Hopefully all of you got it sent out. I believe that it's pretty close to done. I don't know if
we
you
can
guys
share
want
it
to
if
share
you'd
it
like
from,
us to.
so just so everyone can see the beauty that's been done. I think Narda did contact me earlier and say there's a couple little spacing issues that have to be fixed, so that there may be a couple little minor changes to it. But I don't know if anyone had any comments on thoughts. It's a whole lot of names on there when I look at it.
It's a whole lot of titles.
For
Also. A whole lot of titles.
Yeah, so I don't know if anyone had any comments or questions.
And the reason for this is, communication from the board should come from the board chair. We've been using our letterhead, and that's just confusing for the public and for those receiving. Is it me or is it Jack that they need to reach back out to? So just helps to clarify roles and responsibilities.
I'll move that we accept this if we have to have a motion.
I'll second it.
Okay.
I'll say.
Any further discussion? I guess just make sure if you haven't already, check and make sure your name's spelled correctly. I'm sure they are. Any further discussion? All right, Narda, can we do a roll call vote?
This is Narda, and Narda Capicelli, we're doing a vote on the letterhead. Dr. Drake? Dr. Drake?
Yes.
Thank you. Dr. Hurt?
Yes.
Mayor Jacobs?
Sorry, yes.
Dr. O'Brien?
Yes.
Ms. Roma?
Yes.
Dr. Shamia?
Yes.
Dr. Sousa?
Yes.
Ms. Wagner? Ms. Wagner?
Narda, I don't see her any longer.
Okay. And Dr. Buchanan?
Yes.
Thank you. Passes. Thank you very much. Unanimously.
Thank you, Narda. So now we are on to other business, which I think includes what Dr. Buchanan referred to about possible county commission changes.
Yeah, so County Commission has 2 resolutions. I think I emailed those to you today. I thought I'd done that earlier, and I apologize for just doing that today. One is about creating an advisory board on health and economic the economy. Any supporting documentation was not available on the website. Although I think it should be available tomorrow. I think Thursday is when that needs to be there. I did ask, and then so there's that. I'm not sure. I have a lot of questions about the purpose of that and how that would work and how it would interact with us and the Community Health Council that is already an advisory board for health. So just have several questions about that. And then the other one is changing the Knox County ordinance to put some language in there specific to the Board of Health and how we operate. And I actually did get that documentation. So it would change, if there's the declaration of an emergency, it would change that we would have to meet in person if County Commission is meeting in person, that we would allow for a public forum in the same manner as County Commission, and that during public forum, residents will have 3 or 5 minutes. That's and then the provisions of the subsection shall in no way diminish the statutory powers of the County Board of Health. So it's not changing our powers, it's just changing operations in the event there's a declared emergency. So I don't know if I can't really answer questions because I was not involved in authoring either of these. And so certainly if you guys want to have discussion, or the sponsor of both of these is Commissioner Kyle Ward. So certainly if you have questions, you can reach out to him or the law office who helped him write those as well. I believe Mr. Book, the law director, was the one who's helping him pen these. So any discussion or questions, they'll be discussing it. The first reading of the ordinance change will be, so it takes 2 readings of an ordinance change to change an ordinance. So the first reading occurs this month. That meeting will be the work session is on the 19th and the voting session's on the 26th of October. I think that's right. And so then it'll have to have a second reading in November before it becomes an ordinance. So it wouldn't go into effect until late November, early December, when it goes through a second reading. So that's the process that happens for an ordinance change. So that's where we are with that. They'll be discussing it on Monday, and then again the next Monday they'll vote on it. And then if it passes, then it has a second reading in November. So, and happy to try to answer questions.
Thanks, Dr. Buchanan. I guess just one comment is, hypothetically, let's say, I know that's not going to happen, but if it was passed now, I assume that Governor Lee's allowing for groups like us to still meet virtually in the time of a pandemic would still be allowed, or are they, I guess, trying to take that away?
I don't.
I figure you didn't, but
great question.
Throw a question out there.
Yeah. I don't know if Mr. Sanders
other questions or comments
about that.
We'll wait to see whether this passes the commission. If it does, we'll look into issues like that. But until right now, this is all hypothetical. County Commission puts a lot of things on its agenda that don't always pass. So let's see whether this passes, and at that point, we can take a look at what the interplay between the county ordinance and the governor's executive order would be.
Dr. Souza, I had a question for Mr. Sanders as well, if that's okay. So, and you may not want to answer this also because of hypothetical, but I've mentioned several times this has been a civics lesson for me. And so I guess just what's the difference between when something ends up from county commission landing on a ballot versus it just being one and done by them? I mean, aren't there certain things that have to be voted on the ballot and other things that the county commission can do? And what's the differentiator between those things? Or Mayor Jacobs, you can.
So I'll take a first crack at it. I assume when you're talking about on the ballot, you mean the voter ballot that in an election?
That's correct.
Those are amendments to the charter, the actual governing document of the county. And for instance, there are two matters regarding amendment of the charter on this, the current ballot right now. Those are things that go to the actual citizens of Knox County have to vote on. The charter is, for lack of a better term, the constitution of the Knox County. It's the governing document, only subordinate to the laws of the state of Tennessee, and of course, the federal government's laws. Ordinances like what Dr. Buchanan is discussing that's on the agenda now, those are simply the laws that are passed by county commission. They can be undone by county commission. They don't have quite the same weight as the charter, and they're not required to be voted on by the citizens. They're simply voted by the legislative body of the county, which is the county commission.
And Mr. Sanders, we hear that things require 2 readings. Can you explain what that means, please?
Sure. It's simply that when an ordinance is proposed, or for that matter, or revoked, the county commission has to pass the same thing twice. They pass it on the first reading at one meeting, and then at a subsequent meeting, they have to reconsider it and vote on it again. The school board has a similar process in place for when it passes its policies.
Thank you.
Any further questions or comments?
Yeah, this is Maria. I have a question, and forgive me, I'm not sure if it's Mayor Jacobs or Mr. Sanders who can, or anyone can help clarify, if possible, the rationale behind having Board of Health, for example, conduct public forum as county commission. I thought because we as our own entity came up with our rules and regs, I'm a little confused about why or how county commission could make this determination that we need to follow their policy, their rules and regs for something like public forum or meeting in person. I don't know who can help educate me on that. Thank you.
Sanders, you're gonna have to take that one.
Yeah, I'll try to unwind it. Now, first of all, what I'll say is, as far as a subjective rationale, that is, what is in a county commissioner's mind, I can't tell you. You'd have to call that county commissioner and ask him or her. As far as how the procedural aspects apply, this board was governed under the county commission's rules until it had its own rules. At that point, and now you have your own rules. What this ordinance is doing, however, if this ordinance passes, it would actually be an ordinance of Knox County, a law, which would theoretically supersede the individual board's rules. But again, that's something we'll have to parse out if this passes.
Okay, thank you for helping me understand that process.
Further questions or comments? Dr. Shania?
Well, I just want to make sure I don't lose my chance. I had a couple other things, but I just want to make, if we're still on this topic, I have nothing else.
Anyone else on this topic? Okay, if not, I guess we'll wait and see what happens with the readings. Thanks. Okay, Dr. Shania.
So one housekeeping thing and then one bigger thing. The housekeeping thing is I was very proud that I figured out how to log in to that shared forum that we have now, but I don't exactly know what we're going to do with it or how exactly to use it. And so, for example, since we're going to be spending a little more time refining the metrics, hopefully to be done with those, Dr. Buchanan, at the next meeting, is that a place where we can interact back and forth, understanding it's all part of public record and whatnot, between meetings, or what exactly are we supposed to do with that?
Well,
if I could, excuse me, if I could interject, I don't know if that public forum, that electronic forum is going to be ready for prime time yet. Since the time that you discussed having it, our office got an advisory opinion from the Office of Open Records Counsel, which is the office of the state that deals with both open meetings and public records issues. Their word is, their rulings are advice is not binding, but it's very persuasive. And in that context, there was a separate board of Knox County that was an appointed board like this one is, that they said could not make use of a electronic form such as that. That one had to do with handicapped persons. But in any event, the ruling was that because the board only that resource is only available to elected bodies, not appointed bodies, which is a distinction that had been lost on us until then. We need to contact the Office of Open Records Council and figure out exactly what their thought process is and what their feeling is about this entity. But I'm not sure you can rely on using that yet.
Thanks, Mr. Sanders. I guess I've been rewarded for not trying to log in yet.
I'm feeling silly that I went through that process. We're not going to use it.
Well, we'll see. And what was, did you have something else, Dr. Schmidt?
Well, yeah, I did have one other thing. Actually, just a quick comment, and then the other thing. And Dr. Buchanan, I just wanted to mention just a thank you to you and your team for continuing the press briefings and the information that you're conveying. I think that, you know, particularly with us on an every other week meeting cycle, that's going to continue. That's going to be very important to get the current state of information and continue to educate what is a very fatigued public. And so I applaud you guys for doing that, and please keep that up. What I wanted to bring up was that I, somewhat intentionally diverted Dr. Buchanan's question when she was going through the escalation and de-escalation, and didn't want it to really overwhelm the discussion of the metrics, but we may want to talk about that just for a few minutes, knowing that we don't have the pressure of any sort of decision. But in my opinion, that gets, first of all, I've made it clear a few times in this meeting, I've been surprised to some extent with exactly what's played out over the last few weeks. I really don't know what to expect over the next 4 to 6 weeks, although there certainly is concern about what we're seeing. And that really makes, that gets, what's already been dicey, gets dicier pretty fast. And I guess what seems to me is it may become more of a regional issue. And so, in other words, ultimately if the next 4 weeks look like the past 2, for example, let's just hypothetically say that, then, I mean, it really is a regional issue. It's not just a Knox County issue. But anything regionally would have to come from the level of the state and from a public health policy perspective. And I guess I've just not had, and Dr. Gocher alluded to this, our state has taken a different approach than what some other states have. So I wouldn't necessarily see that coming. And so obviously we have the sphere of influence that we have in the county. But back to that table I sent, or we discussed several meetings ago, there's really only a finite number of things that can be done at this point if the situation unravels. And we can set a 10 and a 10 on escalation, but the question really is, what does that look like? And maybe it's so hard to wrap our heads around because it's just not a desirable thing to think about, because it would imply that from my perspective, for example, that hospitalizations got significantly worse than they are right now. And Mayor Jacobs, even from the beginning, I remember one of the first meetings that hospitalizations they're harder to refute than a lot of the other things that we're dealing with. So, I'd be interested in just a little bit of discussion. I mean, what are those things? There's gathering size, which we're at 25 right now. And a whole nother discussion is who follows. Okay, I get that, but there's just to say what there's gathering size, there's targeted business closures and curfews, there's non-essential closures, and then there's, the most extreme, which is a stay at home, which we've already experienced way back when. And quite frankly, that stay at home accomplished something because we didn't have testing and we didn't have PPE at that time. Well, now we have testing and PPE. It's really just a situation of what the COVID status is. And so without the pressure of having to do anything, I didn't know if there was value to just talk through that a little bit tonight. And Dr. Buchanan intended for us to do this earlier, and I diverted things. And so I felt due diligence was to bring it back up.
Well, when we look around our state, right now, Nashville or Davidson County and Shelby County are the two places that have some significant limitations in place still. Hamilton County, I actually spoke with their health director today, and they have a mask mandate in place, and that's the only thing they have in place. So that, they have a very limited anything at all in place in Hamilton County. And we look at, Nashville and Davidson, and they've opened up and closed back down. I think they're in the process of trying to open up again. I think it was, it's really hard to close businesses, even in a targeted fashion. Closing businesses is really hard. But, is at what point would that be necessary, or at what point would we believe that would be necessary and helpful? Certainly if you look around the world and other countries and across the country where they've opened up and had to close back down, it's effective. The flip side is, the consequences, the impact on the economy and the social well-being of our community, but also having hundreds of people hospitalized and die from COVID has an impact on our community as well. You have lost productivity of people who just won't go to work or won't go out and do anything just because they're worried about getting COVID as numbers go up. So neither way is a good solution. Both ways have impacts on the economy and on the health of our community. So I know I didn't help anything, but that's the dilemma. That's where we are.
Further questions, comments? Yeah, I think this kind of brings back to, I don't know if it was the last meeting. Oh, I think it was the last meeting when Dr. Shemaya, we welcomed Ani aboard, and well, he said, we realized that it doesn't really matter what we do. We're going to be criticized. We're really trying to navigate those waters as to not being too harsh on the economy or being, too easy, so that we can hopefully navigate the best we can. Further comments, questions? Something for us to think about as we try to go to sleep tonight. All right, hearing none. Any additional topics and other business? If not, I'll entertain a motion to adjourn.
So moved.
Second.
All right, thanks everyone. We will see you back in 2 weeks, and try and enjoy the nice weather for a few more days. Have a good evening.